always wanted to do a podcast about stem cells. So I'm super excited to finally have found someone who can explain all about it to us. We will be talking with Dr. Jeffrey Gross, who treats patients on a daily basis with stem cells for their back injuries, hip and knee osteoarthritis, shoulder tears, and all the other joys that come with aging and menopause. And Dr. Gross studied biochemistry and molecular cell biology at UC Berkeley. He decided to become a neurosurgeon, but then he shifted his career into regenerative medicine. So now he focuses on treating athletic injuries of the spine, hip, knee, and shoulder at the leading edge of the biological sciences. So he can really help people to depend less on their pharmaceuticals and drugs or avoid surgery if it's not all that necessary. So he founded his regenerative medicine practice called ReCELLebrate in Nevada in the US, where he activates our own stem cell health to heal our bodies and prevent other health issues that may be coming up down the road. So before we move on, let's read the little disclaimer that Dr. Jeffrey Gross does not make any claims to maintain compliance with the FDA, that stem cell therapy and related options quote unquote, cure or treat any disease or condition. So clear that. Now, without further ado, let's meet Dr. Jeffrey Gross. Welcome.
Thank you for having me. It's great to be here.
So before we dive into stem cells, tell us just briefly how or why you went from neurosurgery to the world of stem cells.
Well, I think, it was out of frustration by myself and by my patients who mostly spine patients, people with neck and back trouble. And, we would try everything we could to help them, therapies, medications, time, stretching, what have you. And then sometimes when those things were inadequate to treat pain, then we had a discussion about surgery. And looking back, the surgeries that I learned to do, by and large, had not changed in 60 years. And, I go to annual meetings of spine surgeons and they talk about the new gadget or gizmo to do that surgery. But ultimately, we're either making more room in the spine or stabilizing or locking together parts of the spine. Those are kind of the two main categories of general spine surgery. But patients, didn't want that necessarily. There's a group of patients who just aren't quite bad enough to get there, don't want it. Spine surgery has a bad reputation. It doesn't indicate that you'd get full eradication of your symptoms. So patients were frustrated. Doc, I don't want surgery, but I still have pain. What else is there? How about stem cells? They'd come in and ask me lasers, stem cells, or this or that. And finally, out of frustration with them and for them, about 20 years into my practice, I said, there's got to be something better to fill that gap between the traditional cortisone injections and surgery. So I went back and retrained and went back to my roots of molecular cell biology. And I'd been following stem cells, but really hadn't been able to apply them clinically. So that was the origin of why I got back into this and sort of retooled my practice 2.0.
This is a similar story with so many people I interview who shift careers as doctors and they become frustrated because they can't help or fill in a gap, like you said, too. And or they may be giving them surgery and they're still not getting better with injections and still not getting better. And that's why many of you become doctors to help people. So when you can't help, I can imagine the frustration. So it's amazing that you've gone even further, because that's a whole other education, it's a time investment, money investment, and all that. So it's not easy, I bet, to shift. And I'm glad you did, because I'm excited to learn more about stem cells, and people want to know what we have an idea, but most people have really no clue what really the details about it. And before we kind of go into this, I want to look at the woman who's getting closer to menopause. It's really not unusual that she starts to experience joint pain. That's one of the symptoms. And sometimes it's from an old injury, and sometimes it seems like it comes out of nowhere and we can't even find any structural damage. But women also are just generally more prone to arthritic conditions and have more intense pain than men. This is what I found through some research. And I want to know, why is this happening? And do women in menopause who have these declining hormones, are they just setting themselves up because of that? Or are they more at risk? What's going on with the women, the menopause, and this pain stuff, joint pain?
Yes, I think you kind of answered the question well. You know, a number of years ago, I did study, you know, the hormonal optimization, and you know, the hormones in our bodies, whether they're male or female or what have you, are kind of the oil in our engine. They keep us functioning at an optimal level, and with age, those hormone levels tend to decline. And if you think about it the other way around, some enterprising physicians thought about this about 25 years ago or so. Perhaps we age because they decline, and that's, you know, when they started you know, replacing with the bioidenticals and optimize, not just replacing but optimizing, because everyone has a different level and number, and that has to be done in a precise way. And it's not just a lab value, it's how you feel. And so ultimately, if we have our hormones humming at their optimal level, like when we were youthful, and by youthful that probably means a young adult or in our 20s, um, our inflammation is best controlled. And I said that vaguely because it is kind of a vague word. Inflammation is this chronic degrading of the body's tissues, and they tend to affect things like joints early. The moving parts tend to break first, if you will, and that's where you get words like arthritis or arthritic or rheumatism or bone on bone, but joint pain. And one way to help slow that inflammation and slow the degradation of the joints is to maintain hormone levels.
Interesting. That is definitely, I've heard of that as well, that women feel better once they've topped up or balanced or whatever these words that you want to use, because it is protective in many ways. And I think there's been a lot of misinformation, and we're trying to disrupt that. And so joint pain, yeah, and that's kind of makes sense why women may have more arthritic conditions than men, or more intense pain as well. And there's very interesting studies that have been going on through bioidentical therapy, and glycan age, for example, was interesting. It's one of these biological age test kits, and they see that women, as they are aging up until menopause, we tend to have a lower biological age, meaning how our body is in the inside, not just our chronicle age, the numbers. And then what they're seeing through these kits are, as we hit menopause, we suddenly have this hockey stick curve, intensely accelerated aging. And that's just shocking. And so then we become older than men, because men seem to have their biological age and their chronological age quite similar, or even worse, in a worse condition all throughout their life. But women, just that hockey stick is kind of scary. And then once they put women on the bioidentical hormones, then that curve comes back down again, closer to their chronological age. And very interesting studies that they're doing there. So you know, that's just aging in general. We're getting a biological age, but the joint pain and that suffering and that, you know, symptoms are a whole other ballgame. And so it is interesting to see how that can help. But so let's go. What is there anything else before we dive into the stem cells? Is there anything else that a woman going through this perimenopause experience, what, you know, again, it could be hormones, maybe it's something else, that what she can do in terms of reducing or getting rid of that joint pain?
Well, anything in the anti-inflammatory lifestyle, you know, because anti-inflammatory here is synonymous with slowing aging or anti-aging, which has been a, you know, a parallel of what I've learned to do here for joints and spines. Is now it, you know, branches into anti-aging, but anti-inflammatory diet, lessened exposures to pro-inflammatory environment, whether it's in the water, in the food, in the electromagnetic waves, proper sleep and relaxation and rest, and decreasing neuroinflammation. All the things that would normally go into a healthy pattern in general to slow inflammation in the body.
So do Do you find in your practice that women who exercise regularly, let's say sometimes it's intense or not, do they have more joint problems than women who aren't or more sedentary?
So, this is where the balance of someone's capability is at a certain physical status are important. Exercise is probably the number one thing you can do to reduce inflammation overall. And as a professor of mine used to say, motion is lotion. So we have to keep moving. However, if you do overstress a joint or you have an old sports or injury or something, that joint may limit you or give pain or problems. So one has to work within those complexities. And perhaps with some of the things we'll talk about here in the regenerative medicine or stem cell realm to improve, one bad joint so all the others can have the benefit of movement might be one of the solutions to the issue.
Interesting. So let's move on then to the stem cells, because this is a whole other level. I've done podcasts, interviews regarding platelet-rich plasma injections or PRP. This is another thing that may help alleviate people with their joint pains. And that's the next level would be maybe PRGF, platelet-rich growth factors. And then it seems as though then there's the stem cells and the exosomes. Maybe there's something in between I don't know about. But the top tier, this seems to be the most advanced, or perhaps I'm not sure if it's the most effective, relatively speaking, to these other treatments. Let's take a look at stem cells. What are they, and where do they sit on this spectrum of treatments?
Right. Thank you. You basically gave some of the important tiers, which maybe we should cover, but we are made from stem cells. They are the cells that came from us when we were embryos, and some of them persist in our bodies to help us grow and develop into an adult and then help maintain us. Regenerate liver, regenerate your skin cells, which is an ongoing process, regenerate some cells on the surface of the eye and other places. Well, they're all throughout our body. The main store, the best store, is in our bone marrow. And if you think of it, and I'll take a little diversion off the question for a moment, when you lose your bone density, you really hurt your longevity. And the opposite is you support your bone density, you support your longevity, because there are significant studies that show the more muscle mass and the more bone density you have, and those go together, because if you're moving, you're stimulating both. But the more of those you have, the longer you will live, plain and simple. Okay. And if you look at nursing home populations, you're seeing people with significantly declining bone mass, bone density. And what's in there? They're stem cells. So when you really hurt the source of the renewal in your body that you've had all along, then you're basically saying, okay, well, I can't renew forever. So the stem cells are the cells that can differentiate into the cells you need, whether you need more muscle cells or liver or heart cells after recovering from a heart attack. I mean, that's where they come from. Yes, your body makes growth factors, and most of those are from platelets, but the source, think about the source of those platelets and those growth factors is also the bone marrow. So the bone marrow is really the source of life, and it's source of renewed life. So stem cells, the platelet-derived growth factors, and other platelet-rich plasmas all come from there, including exosomes. So if we're able to stratify, if I can keep going just for a moment, the lowest level, the simplest level of regenerative medicine biologics would be these plasmas, concentrated growth factors or platelet-rich growth factors that can be taken from your own blood. The next level up would be cells, so stem cells, and they come in different forms. We usually talk about what are called MSCs, or mesenchymal stem cells, and these are stem cells that can divide into different tissues. Now, there's research that you can have these cells be reversed with some certain little growth factors called Yamanaka factors, named for Dr. Yamanaka. And those can potentially be something to help treat cancer, and that's being heavily researched, not yet clinically available. Those cells have even more power, but these cells can only differentiate these MSCs into the tissues we need in our body. But it turns out through lots of research and through stem cells that are given as a treatment or an augmentative approach to addressing problems, that these stem cells don't last but 10 to 14 days in the body. But the benefits last for many months. So why is that? Well, it turns out those stem cells are delivering cell-to-cell signaling to our own cells. And by our own cells, I mean our regular cells and our stem cells that with age lose intensity and power. They're exposed to inflammatory changes. They're just not as effective. So you think about a 3-year-old who scrapes his knee on the sidewalk, and 3 days later, that scab is almost completely healed. Well, we don't heal like that, but we could. We have the same biology in our bodies. It's just sluggish. So this activation of our own cells comes through cell-to-cell signaling from youthful active stem cell sources. And that cell-to-cell signaling is called typically a nanoparticle or an exosome. So in my mind, exosome is probably the more efficient, longer lasting, easier to deliver, and less costly regenerative biologic than stem cells. But for the purpose of this podcast and for many podcasts and writings, when we say stem cell biology, we're talking about all these things.
Hey, yes. Yeah, because very often these go hand in hand. And so we just to reiterate, we've got the PRP, the platelet, the growth factors, then we have the stem cells. And it seems like you just said the exosomes are even more powerful or perhaps more cost effective. So that's like top of the tier. And so where does this come from? I know that platelet-rich plasma or PRGF, this stuff, they literally just take your blood out of your arm, they spin in a centrifuge, and then 15 minutes later, they re-inject it. It sends that signal to the body to go and heal and repair itself. How different is a stem cell therapy, or even, we can talk about exosomes too. What is that, the differentiation? What does that look like?
Sure. So there are two sources. There's your own body, and they can be harvested, but really the stem cells, if you do stem cells, the best source is your bone marrow. Yes, they can be harvested from fat, but fat is an inflamed tissue, and we don't want pro-inflammatory signals. So I'm not a big fan of that, although there are some decent results from fat-derived stem cells. I'm a big fan of not using our own tissues, because our tissues, like I said, are sluggish, and they've been exposed to years of inflammation, whether we wanted them to or not. So I don't want to put the old oil back into my car when I do an oil change. So I'm a big fan of the perinatal source. So this is mothers delivering by C-section who are screened and tested and consent to the donation of their afterbirth tissues. What used to be trash is now biological treasure. So the source would be amniotic fluid. It would be the placenta. It would be the umbilical cord. And this is rich in both stem cells and exosomes and growth factors and all the things that make up these biologics. And just as a parenthetical, platelet-derived growth factors and platelet-rich plasma and all these things, they do have some cells and some exosomes in them. So ultimately, the exosomes, when delivered to the body, or the stem cells when they deliver to the body and they make exosomes for the body, those stimulate our own cells to make more platelet-rich growth factors and platelet-derived. So we're cutting out all these middlemen and going right to the source when we deliver exosomes, the source to stimulate our own cells and turn on our own factory, like when it was younger.
You mentioned a couple of times harvesting stem cells. What does that mean?
Well, if you were to have your own stem cells taken from your body, that has to come out of your bone marrow. That means you have to have a pretty good size cannula or trocar, or a very wide needle put into your bone. And it's like a bone marrow biopsy needle. So usually it's from the back of the hip crest. And it can be done, but you feel it. It
It looks
hurts.
painful and sounds painful. I've seen videos on it when I was researching PRP for my own hips and knees and all that, and I saw this video and I was like, "Oh my God, that looks scary and painful." How is it? Is there an alternative to that? Like you said, there was the fat cells, but maybe they're not as, yeah, they're not as clean, I guess.
Again, I don't even recommend what we call auto harvest or taking your own. I recommend we get this off the shelf. I buy it from labs that are compliant, government approved labs in the US, and other countries have it as well. And it's basically this perinatal source. You don't have to use your own at all.
But
In
wouldn't
fact,
it be better to use your own? Your body wouldn't reject it. I mean, is there a rejection, and people tend to like their own molecules, their own cells. So
100%.
wouldn't, if you could tolerate it, would it be better to do your own, harvest your own from your own bone marrow?
Well, it's interesting. That was a theoretical risk. However, it's interesting that stem cells tend to immunomodulate, and that's just a fancy doctor word for temper the immune system. So I haven't really seen, both in my own experience and in the literature, any rejection of stem cells. They sort of are protected and know how to get around the immune system. And to top that off, even we're using more exosomes these days, and exosomes do really not have cell surface markers because they're really not cells. So there's no known rejection of exosomes. I suppose it's theoretical, but it's never been seen. So although your concept is accurate 100%, we just don't see it, and it's not a worry in my mind.
What about somebody who goes to Mexico or some other country where maybe it's not as regulated? Is there a risk? Because you said you get yours from, very, very secure source. What is the risk of somebody doing this in another country where maybe there's less regulation?
I want to speak objectively, and to do that, I have to say I really don't know. I don't mean to disparage what's happening in other countries, because I don't know. And to be fair, a lot of the good work that I base what I do for people on comes from Europe and Asia. So we're not necessarily better in the US. So I just don't know, to be fair.
That's fair enough. Fair enough. You also mentioned, I'm trying to think, it was one of the questions that I had, but anyways, I'll get back to it. It'll come to me. So then the way this is that you inject through just like you would any other, I don't know, steroid injection or PRP injection. Does it look like that in the sense that you just get some big old needle and it's a quick injection and you're done?
Sometimes it depends on what we're addressing. My practice has expanded, where I was doing, mostly spine and brain care as a neurosurgeon, and now I'm doing many more things. Joint work. We do things, intravenous, depending on what we're addressing, from autoimmune issues, inflammatory issues. We talked about supporting the bone marrow and bone density, and plenty of, we'll call it musculoskeletal joints, things like that. We even have, some cosmetic things, and we treat dry eye syndrome by activating the meibomian glands in the eyelid. There are just so many interesting things we're doing now.
Wow. Yeah. See, we're pretty focused on the joints and joint pain in this discussion, but it's a lot of other things that you can take care of with this stem cell therapy. How long has this been going on in terms of actual practice? Let's say not just in the US, but abroad. And how much experience do we have in general of stem cell therapy?
Well, I base a lot of what I do in the joints on the work of Dr. Philippe Hernegal from France. And 2 years ago, he published his 15-year follow-up data from the knee study. And so if you add the 2 years ago, he's now 17 years, at least in an organized study. He may have been doing it before that. So I would say we're close to 20 years of clinical experience.
And do we know how many people are in that study? Is it a large or a medium, small?
I'd have to look it up, but I think there were over 100 registrants in the study,
Mhm.
and they have followed these patients and have wonderful results. And my protocol is largely based on that study.
So, what about the risks to stem cell therapy? Can things go wrong?
Well, anything has risks, right? You inject someone, and there's a risk of infection if you don't do it in a clean and sterile way. There's always a risk of hitting an artery and causing bleeding, or a hematoma, which is a collection of blood. These are true for any type of injection. But hopefully we do these so many times that we do our best to avoid these structures as best as we can. Um, and I haven't seen any other risks. There's some soreness for a few days, but I know that one of your proposed questions had to deal with platelet derived growth factors and things, and how you spoke to a Russian doctor
No,
who
it was
who
a
saw.
doctor in Spain, yeah, who said he was doing research on stem cells. I think he wants to go in that field. And he said, because and I asked him about stem cells. Hey, what about that? And he said, oh, yeah, a lot of studies I looked at in Russia led to cancerous cell growth. So my question was like, is this true? Can things go wrong that way?
I have scoured the literature, and I did another literature search for about an hour before we went on the air here, and I can find nothing that indicates that regenerative medicine in these forms uh, can induce cancer of any kind. If you reverse the cells, as I was alluding to earlier, then they may have a potential to become what we call as multipotent, or even pluripotent, or beyond, or omnipotent. And those cells can form anything, right? So we don't want to drive them back that far. We want just these, multipotent, rather. I think I said that in the earlier group, but multipotent means it just develop into any type of cell we have.
The MSCs, right?
Right.
Okay, the mesenchymal cells. So yeah, there's like you mentioned, there's several different types of cells. So in your practice, and I'm guessing in the majority of the people's practices, they're using MSCs for their stem cell therapy, correct?
Well, I'm in the exosome camp most of the time. So but the vast majority of the world is using MSCs.
Okay. You mentioned it's always best to get the youngest cells, and that's why you use umbilical cords. And I'm so regretting not saving my placenta and umbilical cords of my children when I gave birth, and it's too late. But is it too late for somebody, let's say in their 70s, 80s, when their cells are already in a different state than much farther than when they were born? Can we use those if they wanted to, if they didn't want to go down the umbilical cord route?
You can. I don't advise it. I wouldn't want that, but you can. There are stem cells still active in a person of that age, and you'd have to harvest them and concentrate them better. But I think it's a long way to go for a short benefit. I would go with the youngest, best, most effective, unadulterated, uninflamed biologic.
So that's so you're saying then that, yeah, the older you are, the more degraded, or maybe perhaps the less effective the stem cell therapy may be. Is that correct?
That's absolutely correct. These cells have been exposed to the same inflammatory burden that someone has been exposed to over all those decades.
Hmm. Okay. So let's talk about then the procedure. Does this happen in a clinic? Do you have to go to a hospital? How long does it take? I know what PRP is, and that literally it's like 30 minutes. You're in and out of just a little clinic. It's so fast. Some people I know do it in their homes. The doctor comes with their centrifuge. It seems like quite a fast procedure. How does stem cell therapy compare?
Well, most of the work is done ahead of time, and this is what we call, personalized precision medicine. Most of my patients don't live where I am, and I'm speaking to you from Henderson, Nevada, which is a suburb of Las Vegas, Nevada. And most of our clients have found us remotely, and we start the process like this by Zoom. We get their records. We make sure their bodies are optimized with the right supplements and lifestyles and things, because if we're going to do this, we want it to have the best results. And then we do need to look at the joint in detail. Most people come to us and say, my doctor says I have arthritis. My doctor says I have bone on bone. But that doesn't tell us exactly what's going on in the joint. So we get usually an MRI study, and it has to be ordered at the highest quality and the right images. It can't be just a run-of-the-mill, MRI. So most people, we help them get that remotely. We get the results here. We put it on the screen. I share the screen. We show them the pictures, and we'll look for the individual targets for a joint. And those targets are usually in the bone marrow adjacent to the joint. Again, this is the French protocol, and we have echoed their results. And once that's all set, then they can make travels to Las Vegas, plan a little trip around it, and then we bring them in. Some people need an MRI, and they get to the airport, go right to the MRI center, come right to my office, and we go over things. But the actual procedure is done in a clean, sterile injection facility under fluoroscopy guidance with a little bit of sedation. A single joint might not take me 15 minutes, but most of the time and effort is ahead of time. Once we know where to go, that's just finishing it up, really.
Do you use an ultrasound to try to find out exactly where, or you just,
We use a fluoroscopy machine, which is a video x-ray, but the x-ray tells us where to go, but we already know where we're targeting based on the MRI study and based on the examination. Some people come in and their MRI has lots of findings, but they only hurt in one place. So we want to focus on where the problem is, not just what looks bad on the imaging.
So you need to inject in the site of the problem. If it's the shoulder, you inject the shoulder. It's not a systemic thing where you just put it in your belly and done. It goes to the site. You need to actually target an area, right?
It's even more targeted than that. It's a specific areas in the shoulder. Shoulder's a big joint, right? We want to be more specific and hit exactly, we want the best results. So we will concentrate in that area. Are there people who come in with, I've got lots of joint pain, my bone density is not so great. Yeah, and the intravenous route may be the thing to start with. It's not gonna give you the same type of focused intensity of a precise injection. However, it depends on the issue. And sometimes we do a mix. They have little aches and pains everywhere. We address that with an IV, and then we see what's remaining. And if it's my knee, then we'll treat the knee separately, directly.
You mentioned there's a protocol. I'm not sure if it's pre-injection or if it's taking out the blood. What is that procedure? Is there before and after things that you need to do?
The procedure is not invasive. We don't take any blood. I'm using off-the-shelf perinatal exosomes.
Oh, that's right. Yeah.
Almost routinely. It's almost too easy. It's a lot easier than the complex spine and brain surgeries I used to do, for sure. But the protocol before is basically getting the body ready, making sure they're maximizing the anti-inflammatory lifestyle. In some cases, it could be bioidentical hormone optimization. It could be changing a few lifestyle issues, diet, what have you. We want the body the best state to receive and benefit from these regenerative approaches.
So I've heard that in other areas in my research, that people who do, I think they are extracting the bone marrow, they like to get their patients on Xenolytics to get rid of the damaged cells, or the ones that are not so great, and then put them in an optimal state. And I know you're not doing that, but I was wondering if that would be an interesting protocol, even despite you're not taking out your blood or the bone marrow, but you are actually with the injection. Would that help somebody, or does that already not apply?
Oh, it could definitely be part of an individual's preparation and ongoing way of addressing, how one clears out the senescent cells. So Xenolytics can easily be part of that. We do talk about Xenolytics. Many of them are not approved for claims in the United States, but we do talk about them, and they can be obtained and used.
Okay, so you would inform your patients, okay, take Xenolytics a month before and the injection, and I don't know if that was even worth doing after, but there is
Yeah.
a possibility. So, and to clean up their diet and lifestyle, that just, yeah, priming the environment, I guess, would be good. But some other people who were doing stem cell therapy, they would say, actually, no, it doesn't matter if the body's in an inflammatory state. We don't really care. The stem cells know what to do. If you actually remove all the inflammation, that doesn't really know where to go or where to target. That's how they sort of the signaling process. What do you say about that?
There is a signaling process by which places of more intense local inflammation release cytokines, which are small proteins that call for help, and that stem cells are attracted to those areas. So yes, that's a known phenomenon. And even though we deliver some of these things directly near a joint, we can really help. The cell signaling helps, but that doesn't the effect of Xenolytics and body preparation and changing the inflammatory burden doesn't become negligible when someone is having these types of treatment approaches. Every little bit helps, and some of these the glycan age, some of the other age biological age tests, you can get an idea of the rate of aging, and all these approaches to suppressing inflammation help to slow the rate of biological aging.
What about how long does it take for someone to feel the effects of the therapy, whether it's a shoulder pain or joints, knees, backs? How long does it take?
Well, these regenerative biologics, stem cells, exosomes, what have you, flip the cell metabolism and pathways from one of an inflammatory one to a fighting inflammation, anti-inflammatory pathway. And sometimes right away, people have reduction in pain because of the inflammatory component of that pain. The regeneration component takes months. I just spoke to someone last week who was 3 months after a knee and some ankle procedures, and the person just had probably no more than 25% benefit for the first 3 months, but turned the corner. And last time we talked was the 3-month mark, and they were 50% better in the worst joint and 85% better in the best joint. So that's the ongoing many months of regenerative activity where we're stimulating the stem cells to make the cartilage that it made in the first place when that factory formed it as a fetus and a baby. We're just tapping back in and asking the factory to make the equipment again.
It's incredible what we can do. It's really amazing. It's fascinating. So I'm wondering then, in your experience with your clients, and as well as what does the research show in terms of the efficacy rate? What's the percentage of people who have success? Because I remember when I was doing research for PRP, the research was showing somewhere between 50 and 80% success. What is it for stem cell therapy?
Well, going off the French study that has published the 15-year follow-up 2 years ago, I think is our longest lasting and most robust study. And in this study, they took patients who were end-stage cartilage degeneration of the knee. So you might refer to that as bone on bone or grade 4 chondromalacia or osteoarthritis or any other word that people would use. It's the same thing, right? They took these patients, said, hey, instead of having a knee replacement, would you like to join our study? And of course, many people said, yeah, I'll try that. And half the patients in the study got stem cell concentrate injections from their own body. This is because 15 or 17 years ago, that's all that was available. No exosomes were directly available anyway. Stem cell injections concentrated from their own bone marrow, injected either half of them into the bone above and below the joint, and half of them into the joint cartilage itself, what we call interarticular. So It turns out by 15 years, looking back, early on, many of the patients did well, but by 15 years, the patients who had the intra-articular injections, only about 25% of them were still doing well. But the bone injected people were about 83% still doing well, meaning their joints no longer needed that knee replacement surgery they were recommended 15 years earlier. So it turns out there's these bone injections are stimulating the factory, the stem cells in the bone that make the protein and cartilage proteins that make cartilage. So they were regenerating the cartilage, the lubrication of the cartilage, the nutrients to the cartilage, and reducing the inflammation that was causing the degeneration of the joint in the first place. And if you work towards repairing those things, then the pain and the improves, the function improves. So I follow that protocol. We're injecting the bone just above and below the joint. We're doing the same in the spine. We're doing it in the hip, the knee, and other joints.
And they only got one injection and that's it? One treatment?
No, there were a couple different studies. One was a single, one was a double. But we are getting the results with a single exosome procedure. And I have not yet had anyone who needed a second one.
Wow. And how long have you been doing this?
We're on our 5th year, although we've been gaining more volume in the last year or two, just because this is catching traction and word is getting out.
That's really good news, because I know that PRP generally, in my experience and those I read about everywhere else, they have to do it every year. It's kind of a maintenance thing. It's not actually reversing anything, but it is keeping you going. So it actually sounds like maybe it's a better investment. Just do it once and get it over with, because it's expensive, isn't it? The stem cell therapy. How much are we talking about?
Yeah, so I purchased the biologics, the exosomes, and we have to, of course, pay for the surgery center and the anesthesiologist for sedation. This isn't general anesthesia; it's just sedation. So a single joint is usually 2 doses, one above and below the knee, for example, and something like that runs around 85 to 9,500, depending on my cost of the biologics, US, which actually isn't bad. You think about the time and cost of surgery and the downtime, or 3 rounds of PRP, you're almost there anyway.
But insurance pays for a surgery. That's is what drives me crazy, because that's why people will just go ahead and do that, because this stem cell therapy is usually out of pocket, right?
Yeah, it is. Insurance pressures. We shouldn't even be able to use the word insurance. They really only insure what they want to insure. So they don't pay for it. So we most of our clients are using HSA plans or health savings account plans, because they can control that, or other means. Correct.
I think everybody needs to have some kind of a plan or a budget as we age. Probably should start from childhood, and just don't touch that money, because you will probably need it as you get older because of the insurance not paying for things. And we really need to do that. So I'm wondering then, what is as I remember the first time I heard about stem cell therapy, I don't know, maybe 10 or 15, maybe 20 years ago, I don't remember. It was illegal. Like, you couldn't do it. And there was all this controversy. Where are we now? Is it legal in most areas? Like, obviously now in the US, you're doing this, or is there any problems still?
I don't know that it's ever actually been illegal. The issue is the FDA, as we mentioned on the outset of the podcast. The FDA regulates what claims can be made for a product, or food, or medicines, or supplements, or surgical implants. So I am not allowed to make a claim that any of these regenerative biologics, including PRP, can treat or cure a disease or condition. That's their words. So that is violating an FDA statute. So I don't do that, and I make it clear to all my clients or anyone I talk to We don't want to violate that. So I make clear that I can't make those claims. I can talk about people I've addressed, and I can't guarantee that we get those results for any individual. But as a physician, I've never guaranteed anything in my entire career because I can't. We can't do that. So as long as we don't run afoul of the FDA, it's very interesting because some insurance companies pay for PRP now.
That's amazing.
The amazing thing is it's still not FDA approved for claims. So people mistake the word approved for being unapproved, and that's not true. The FDA also hasn't unapproved these things, and they don't have the authority to say what we can and can't do. We have to do what's best for our patients with full informed consent, and let the patient, of course, be directly involved in the decision and opinions. But they approve claims. So some people have twisted that into there's no proof this works, and there's plenty of scientific work. I mean, there are thousands and thousands of articles at a growing rate. And the FDA decides when it's time or when it's brought to them to get this approved. There's a lot of pressure on them to get this done.
Well, the FDA approves ding dongs and Pringles, so sometimes I question whether it's even valuable. Okay, very interesting. So perhaps it was the use of umbilical cords or something that was controversial. It was something I remember going, "Ooh, interesting. Let's watch this space." But what about the candidate for stem cell therapy? Are there any contraindications or people who really just have you declined anyone because you said, you know what, you're not a candidate?
Yes and yes. Anyone who's dependent on a blood thinner, prevention of heart attack or stroke, and can't come off the blood thinner long enough to have the treatment, we can't treat because we're doing a needle procedure. Secondly, anyone who's got active cancer or recent cancer, we won't treat because we just don't have enough information. I don't want to make that problem worse. I don't know that it would, but I also don't want to be the one to find out.
Got it. So I'm going to open up the mic for our guest and ask questions or comments or anything before, because I got a lot of more other questions, but I'm gonna leave the last 5 minutes for anyone who wants to say anything. Would you like to unmute or type or anything like that?
Hello.
Hello.
Hello. Hi, Dr. Jeffrey. Thank you for this intervention today. I mean, stem cells is something, I'm interested, obviously. I've done PRP. The thing as you mentioned, PRP lasts only for a few months. And so it's like an ongoing treatment for life. First of all, it costs, money. And this is not sustainable. I just want to find something that I can do once and repeat. As you mentioned, it's been 5 years since you started, and in 5 years you haven't had to repeat it yet. But obviously, it's going to happen. But this is a long, long time, much better than PRP. So this is something. I'm currently in Spain, so I don't know if in Europe there is any centers like yours. I mean, it's a long way to go to Nevada for me. But what I'm interested is when you mentioned about our own stem cells. Obviously, they get over time with the age get a little bit. They're not very as efficient as a newborn. Of course, I totally get it. My question is about for this placenta and exosome, which come from baby umbilical cord, and is the vaccine, the COVID vaccine, not vaccinated, and I'm aware of this COVID vaccine. Is this something you personally look at? For select when you do the selection, because you mentioned that what you select is well traced and everything, but what about the COVID vaccine?
Yeah, it's a great question, Corinne. Thank you. So I'm going to answer a few of your comments. First, I think there are places in Europe. I did some homework before we got on here, and I'm not the only person who follows this protocol for joints. I'm not the only person who is exosome friendly. There are other places, and you don't have to come to Nevada for this. Secondly, different labs supply these materials to us in the US. And earlier this year, I switched to a lab who now is only using donors who have not been vaccinated. Not because we have a known concern, well, not because we know there is an issue, but because there's a question, right? We are now starting to see literature, scientific literature supporting problems from the vaccine. So to avoid the question, we now have a source of unvaccinated donors from a particular lab where I acquire materials. We were using, labs who did not screen for that. So that means some of the donors had the vaccine, some did not. But now in the post-pandemic world, it's smart to pay attention. I agree with you.
It's going to be asked. The question is going to be more and more asked. That is for sure. So
Agreed.
we have to be prepared on this. I mean, in the scientific world and lab and all this, because this is a question always into my mind for anything I'm thinking of.
Yes, agreed, 100%.
Thank you.
Well, Dr. Gross, you actually said you follow the protocol of someone in France, and is that somebody she could get in touch with?
Yes, thank you, Zora.
I believe that Dr. Hernagau's group is academic, so they probably at a university, and I'd have to look up the paper. And if you want, I'll send it along, Zora, to you, and you can share it with your audience.
Please, yes.
Where they're located, and then what they're doing. They still may be doing bone marrow concentrate. I don't know, but they're getting good results. So you can't argue with facts. Well, you can, but then you just be beating your head against the wall.
Okay.
One question I was wondering, I heard that stem cells can also heal the gut or help with gut issues. Is that true?
Anything in the body that has an inflammatory basis, and that's vague because so many pathways of degradation and degeneration are based on proteins of inflammation. Proteins being what the cells are doing and making. Gut is one of them. Gut is highly sensitive to inflammation because it's kind of the inside skin, really. It's, we have skin on the outside, and we have the gastrointestinal tract, which is technically outside the body, right? Even though it's in us, it passes through us. It's like a hole within us. So the lining of the gastrointestinal tract is more sensitive than skin. Skin has had to deal with the environment more. So there is an inflammatory response, and then you get into problems when it's so inflamed, like leaky gut syndromes and all these things. So regenerative medicine can reduce inflammation in the gastrointestinal tract, yes.
Through stem cells, or are you talking about some other regenerative medicine procedure?
When we speak of regenerative medicine, it could be stem cells, it could be exosomes, it could be some combination, it could even be some of these platelet-derived growth factors or platelet-rich plasmas used in the right way.
Mm-hmm. Interesting. Okay. I'm going to have to let you go. I've got still a lot of questions. I hope to have you back. If somebody wants more information, can they reach out to you for consultation no matter where they are in the world? And is there a charge for this, or they have to be in person?
If they mention your name and that they found us on this podcast, we will waive the consultation charge.
Oh, nice. Thank you.
But they have to mention your name.
Zora, in case they don't know.
Yeah, and we would love to meet people from all over and offer advice. I enjoy this. I have new passion again in practicing because of this. So I would love to help anyone I can.
Thank Thank you. Very, very thoughtful. I will have links to all of your website, your TikTok, Insta, Facebook. You got all of this stuff everywhere. It's always ReCELLebrate with the double L, like cell. Okay. If you can remember that, ReCELLebrate. I have links there. And you've got a freebie for us, which is very interesting. I have a link to that. The freebie is, I think, a questionnaire and helps people figure out which treatments for them, or what was that?
Yes, so there's a fun questionnaire. There's a link. You can also go. We have a freebie for if you type in ReCELLebrate/back pain. We have ReCELLebrate/joint pain. There are lots of little guides and freebies and answer some of the questions you may have. So please, and whatever we can do.
Awesome. So before I let you go, any last words for a woman going through menopause?
Exercise would be the number one thing you can do to reduce inflammation and slow the process. Diet, sleep, rest, breathing, all that's important, but exercise, keep moving. Weight-bearing exercise stimulates your organs of longevity, your bone density and your muscle mass.
When you say exercise, what does that mean? Walking,
well,
yoga?
that would be a whole different podcast, perhaps. But weight-bearing exercise, so some resistance work with exercise bands or weights, and then something involving using the feet on the ground. So walking, jogging, power walking, bicycling and swimming really don't count as weight-bearing per se, although they're good for the heart. So we want people pounding the pavement.
Awesome. Thank you so much. I'm excited to have you on again. I hope everybody found this super useful, and I hope you have a great day in Nevada. Thank you.